let's turn it over to your colleague there locally. If we could have the next slide, I'll turn it over to Dr. Laura Hagemeyer. This is all about a partnership between local health departments and clinical care providers, and we'll hear from Laura about her role in that partnership. Thank you.
Thanks, Dr. Ward. And Jenny, thanks for the reminders of the importance of those conversations. Even when we think that our patients maybe are well educated, it's important to remember those conversations need to be had. As mentioned, my name is Laura Hagemeyer. I am a pediatrician and the newborn nursery medical director at the University of Minnesota Masonic Children's Hospital. And I'm excited to talk to you about some of the nuances of newborn care as it relates to hepatitis B vaccine and some of the other newborn interventions that happen in the newborn hospital. Next slide. So being the first provider to care for a newborn is an amazing honor, privilege, and also a challenge. As you can imagine, there is so much going on in those first few hours of life. However, it is a really unique opportunity for us to provide ongoing assessment, education, intervention, and health prevention for all newborns that really does affect their trajectory of healthcare going forward. So what happens in the newborn hospitalization affects what happens at next clinic visits and the family's ability and desire to continue interacting with the healthcare system. So it's really important to get off on the right foot. So as a provider, there's a lot to think about. And maybe, Jenny, this goes back to why your providers didn't talk about hepatitis B. But there are so many things that we have to think about. First of all, as we've seen on previous slides, the infant's health can really be affected by maternal health conditions. Hepatitis B is one of these things, but many other maternal health conditions can impact the health of the infant and affect our decision making. If you think about it, these babies go from relying on the placenta and the delivering parent's body for most of their physiology to needing to do it all on their own in a matter of seconds. As soon as that cord is cut, boom, they're on their own. If you want to talk about learning to fly, that is about the time they have to do it. And their physiology is changing minute to minute, which makes it really interesting to provide medical care to these infants. And not only are their bodies adjusting to life on the outside, like I like to tell parents, but they've never been examined by a provider before. They may have had ultrasounds, they may have had prenatal testing, they may have had some information that we think about some conditions that may be happening, but they've never been hands-on examined, which gives us a really unique opportunity to identify pathology and identify additional challenges that these babies might have. And lastly, it's not only an intense physical transition, but an emotional one as well. Welcoming a new baby into the world is a really vulnerable and stressful time for families often, but also can be described as the happiest times in their life. So our approach and our interventions during this time, like I said, are really influential in the long-term health and well-being of these infants. So as we are aware of the vulnerability and the impact we can have, it allows us to provide comprehensive care and hopefully care that will get them onto the right steps moving forward. Next slide. So just briefly, some of the additional medications that babies may encounter in those first few days of life. This is not by any means an all-exhaustive list, but the eyes and thighs, as many nurses will say, are those first initial medications usually given within a few hours of birth, up to 24 hours of birth, are vitamin K, which is a vitamin that's injection that's given intramuscularly to help prevent bleeding for babies. Erythromycin eye ointment, which is an antibiotic eye ointment used to prevent infections in the eye. And then the hepatitis B vaccine, as we've talked about, to help prevent perinatal and early transmission of hepatitis B infection to these infants. These are probably the most standard medications that most, if not all, babies will get in the first 24 hours of life. Additional things like dextrose, sugar that's given oral or IV, depending on risk factors and baby's needs. Sometimes if there is a risk for or identification evidence of a systemic infection, they might get some antibiotics. And then more recently, some hospitals are offering RSV monoclonal antibody or nirsevimab for RSV protection during the birth hospitalization. So there's a lot of things that families are offered or kind of given in those early days, which if they haven't been talked about previously can be a lot for families to take in. Next slide. In addition to the medications and then also reviewing the delivering parent's health history, pregnancy history, all the prenatal screenings and things like that, there's a lot of other standard screenings that are done in the newborn period. Generally, these are legislated at the state level. So each state kind of has a plan for which of these screens are going to be done. Some of these are local or hospital system based as well. So you may see differences based on your location and the systems that you work in. But the goal of these are to have as close to universal screening as possible for conditions where early identification and treatment changes long-term outcomes for these patients. So in the US, all 50 states and US territories mandate newborn hearing screening be offered to families in the birth hospitalization. This is generally a relatively easy test to detect hearing loss and to facilitate early identification and intervention for babies who do have hearing loss. Similarly, all states have implemented some sort of cardiac disease screening or screening for occult or kind of hidden congenital heart defects. Usually this is with pulse oximetry, checking oxygen saturations for babies, but there are other some differences at the state level for what constitutes different screening. And then the newborn metabolic screen is a blood spot test that generally is run by the state health departments, looking at a variety of different metabolic, genetic, and hematologic conditions that, again, with early intervention and identification, have better health outcomes for our patients. It's important to note that the newborn metabolic screen is variable. So in Minnesota, we have a really robust newborn metabolic screening program and have over 60 different conditions that are screened on that test, but there are many states that don't have that. So when patients are born in different states, you may be missing some things if you're used to what your state offers. Jaundice screening and glucose screening are, again, not mandated screenings, but they're treatable, preventable, common newborn conditions that most hospital systems have some type of protocol or policy on how those screenings happen in the first 24 to 48 hours of life. And these just add to the things that are needing to be done in that newborn period. Next slide. As you can imagine, this seems like a lot of intervention and a lot of stuff to do for a brand new baby. And as you're a parent, just holding that baby and meeting them for the first time, sometimes there's hesitations about are some or all of these interventions necessary. This can range from kind of gentle questioning of necessity to blatant refusal of testing and screening. But really, there's a lot of different reasons that parents have hesitation. And most often parents are just concerned it is just too much for their little bodies. And even in my 14 years in practice, I've seen so many things added to the newborn and postpartum care process that these families, they have a revolving door in their hospital room. So they're just constantly, someone is in and out of their room, like we'll talk about on the next slide. But there's just so many things going on. And as each person comes in and is completing their necessary task, parents are questioning, like, how much more do we have to do? Also, you can see on the slide, there are some of the other common hesitations parents have. And when I hear these reasons, or when I sense or see hesitation or refusal or declination of certain medications that are given in those initial hours before I see the patient, it's really my cue to slow down, start asking questions, and really try to understand what is going on, which we'll talk about with some of the strategies on my next slide. So my job would be a lot easier if these conversations had happened prenatally, but I totally understand why I can't. A lot of times in the visits for the pregnant patient, much of the conversation and the education is around things that they are currently experiencing or about to experience as a pregnant person. That baby is on the inside and considered to be in a pretty safe spot. And sometimes the things that will happen to baby after they're born are kind of pushed off out of conversation. Oftentimes they are present in prenatal education booklets or maybe in hospital tours or birth education classes, but often not in places where people can ask providers questions. So if we were able to start some of these conversations early, that would be great. Like I said, often that doesn't happen. So when I have families with hesitations, the most important things I do are sit down, get at eye level, and really use open-ended conversations and non-judgmental language to get at the core or the specifics of the concerns that people have. Once we kind of have figured out where they're starting from, I think it's really important to kind of pause and ask permission to have a conversation about them. Of course, there are things that as a provider, I must tell the risks and benefits of refusing certain medications and interventions, but also I don't need to always have those conversations at that very minute. So sometimes being able to pause and say, I'd really love to have a conversation about the hepatitis B birth dose. Um, is now an okay time, or would you prefer I come back and we talk about that later? And you'd be amazed at, instead of going in with your agenda, offering up their agenda, how much that opens up the conversation to maybe say, sure, let's have a quick conversation about it. Or, now's not a really great time, but if you could drop off some information, we can talk about it later. And even opening that door to prevent an immediate refusal gives opportunity to share that education. Next slide. So some of the systemic things we can do to improve uptake are, things that hopefully most of our birth hospitals and delivering facilities are doing. But if not, these are things where I think we can make really good improvements in uptake of newborn medications and screenings. So as I noted, there's a revolving door that makes it really hard to get rest for families to bond and for families to heal physically and emotionally from the delivery process. Clustering of cares and trying to get things done in a short period of time, or in as many things at one time as possible, can be really helpful to, one, help decrease stress on the infant, stress on the parents, and not allow parents to get kind of stressed or worried about all of the different times that their infant is getting unwrapped and bothered. Many hospitals will do this in kind of a bundle process, or a birth bundle and a 24-hour bundle where they have as many things as they can clustered at a certain time. But if you don't have those things in your hospital, setting the expectations, having the nurses set the expectations of this is what happens and when with families can be really powerful to give them an opportunity to have some uninterrupted time in between those clustering of cares. Standing orders where nurses are able to access medications in the moment instead of waiting for providers can be helpful. Opt out instead of opt in policies and language is also helpful. If you think about the wording saying, vitamin K and hepatitis B are two medications we give to babies to help protect them in the newborn period. We administer them to all babies and we'll make sure we're keeping your baby comfortable. Is now an okay time to do this medication? Sounds a lot different than, can I give your baby the shot? I think it's really important to think about our words and how those things might affect how we approach families. I know we are close on time there, but additionally, making sure that our education across the community is standard to make sure that all families are getting the same information and it's not necessarily dependent on those immediate postpartum visits to provide all education. Last slide. Making sure that these babies are comfortable when this happens and families feel that we are treating their babies with care and concern can also go a really long way. Most parents don't want to see their babies in pain. So these are some of the things we can do to offer comfort to their babies during immunizations or during painful procedures. Allowing the parent to breastfeed or offer sweeties or sucrose and a pacifier has been shown in many studies to provide improved pain response and decreased pain response in infants. Holding them skin to skin in positions of comfort, offering swaddling, offering topical anesthetics when possible. These things are all going to be things that help keep their babies comfortable and hopefully help families have less stress response to the care that we're giving. So partnering with these families as really early and often is a key to overcoming the hesitation that parents have with treatment of their babies in the newborn nursery. And none of us are here to harm babies. So we're all trying to do our best for the babies, both parents, staff, and providers. So trying to keep that in mind sometimes helps us keep our goals in perspective and color some of those conversations in ways that can be helpful. All right, I will pass it off to you, Dr. Ward.
Okay, thank you. That's a great overview to show how how hepatitis B vaccine has to be integrated at that critical moment that you laid out. I had two quick questions. One, is Hep B vaccine sort of included in that general approval process, or agreement with the parents, or do you have to have a separate agreement for them to get that vaccine? And then separately, do you think what do you see as the role of community-based organizations to start that education process earlier than when you see the patient?
Yeah, so there's not a specific consent form or anything that needs to be signed for hepatitis B, but they do need assent. So we do need to ask families before we administer the medication. I find bundling it with our other interventions to be the most successful and saying, this is one of the standard medications that we give. However, we do have to have specific assent from families before we give that medication. The second question, I think the community education piece of things, two things. One, making sure that it's evidence-based and helpful information is really important, and not making sure it's not just anecdotal evidence, or anecdotal stories. But I think trying to standardize in a way that is accessible to families and encourages them to ask the questions early, because I find those conversations are a lot easier to have before we're sitting there with a crying baby in front of us and I'm trying to get all of these things done in a short period of time. So, whatever the education is, making sure it's evidence-based and offered, in a standard way to patients early before they, need to make that decision can be helpful.
Thank you so much.